friends, I'll be talking about the dual mobility used in revision THR, the current status, and the long-term results. So friends, when we are doing a THR, whether primary or revision, we are concerned about the functional outcome, dislocation, and survivorship. And THR being one of the most successful procedures, but still carries a dislocation risk of up to 9% in primaries, then 30% in revisions, and it's a major cause of readmissions and revision surgeries. Over the years, we have improved with time. There are now fewer dislocations, still 1.8% dislocations in primary. We have understood the art of jump distance, safe zones, hip-spine relations, and probably the approaches as well. But instability still remains an issue. Almost 5,000 dislocations per year in USA. And still alarming, the re-revision rate, revision rates for instability is still ranging from 14 to 22%, and re-revision is up to the tune of 30%. So friends, when you are managing instability, if you are revising a hip for instability, you need to solve the problem. But if you are revising the hip for other reasons, do not create instability. Just remember that. And there are many risk factors for dislocation during revision THRs, the most important being the multiple prior hip surgeries, prior instability, abductor dysfunctions, poor quality soft tissue which may be lax or which may be too much of fibrotic, then bone loss, forcing the surgeon to put the implant in wrong orientation, then number of other causes. So if you look at the literature, in Whiter Review published in 2018, most of the series, they were done for recurrent dislocations or for all other high-risk revisions. Most of them having survivorship of above 90%, and redislocation or dislocation rate well under 3% in most of the series except one series which was up to 5%. And a recent publication, 93 patients, 7-year follow-up, just 2.1% dislocation. And more important than that is it doesn't cause increase early aseptic loosening. That is the most important aspect which we need to look into. And my indication for dual mobility in revision scenario is when you have deficient abductors, recurrent dislocations, poor soft tissues, which may be lax or fibrotic, or when I am converting hemis into THA, multiple previous surgeries, metal-on-metal revision, and stiff spine and stiff knee. I have added stiff knee because most of the time we are talking about the stiff spine, but if you have a stiff knee, you have a longer lever arm and that can lead to dislocation. So always look into your knee as well. Few examples, a 70-year female infected hemi converted to spacer, 2-stage, and then a cemented dual mobility and a long modular stem, 7 years follow-up. Another interesting patient, 65 years, anesthetist, working on this for many, many years. That has led to a lot of bone loss in the acetabulum. A trabecular metal shell with modular dual mobility and a short stem. And this is 3 years follow-up. Now it's 5 years follow-up, in fact, and he's very happy about this. Another 80 years old female, aseptic loosening. And this is 3 years follow-up with trabecular metal modular dual mobility. And coming to the use in the recurrent dislocation, that's the indication for dual mobility. And most of the series, they show very low redislocation rate, always less than 2%, and no osteolysis or fixation failure in the final follow-up. A couple of these examples. I prefer to revise them with monoblock, but sometimes I have to use modular. If you have a well-fixed cup, well-oriented cup, and still having recurrent dislocation, like this gentleman started having recurrent dislocations after 14 years, you can always do cup in cup. You don't need to remove the cup. Just cement dual mobility into the original cup. And it's well supported by the literature, just one loosening at the cemented interface, so don't worry about that. Another patient, multiple revision surgery somewhere else, And I did a custom-made tri-flange, and then I had to cement the dual mobility cup inside that, and he's doing well since last 6 months. Another patient, multiple previous surgeries, abductor deficients, and two-stage stem and modular dual mobility cup. When you are converting your patients into hemiarthroplasty, historically they have a high failure rate, high redislocation rate, like 20%. But if you do that with dual mobility, almost none of your patients will dislocate. And if you compare that with large head, the dual mobility is a winner. And I have revised n number of these bipolars. These joints are used to higher range of motion, so dual mobility is a better implant for these people. Now coming to wear and tear. I mean, many people will contest this, that they wear more, but it's not the same. The two articulation of dual mobility do not cause more wear. It's as low as the wear of the cemented polyethylene liner and even lower than the non-cemented liners. Just one example for that. This was done by me in 2007. I revised this broken bipolar with a long Wagner stem and a dual mobility 2007. He came back to me 2023 with pain and osteolysis in the proximal part of the femur. I ruled out the infection, opened it up, and the skirt was the problem. The skirt was eroding the margins of the poly. So I just took a longer skirt, revised it, and he's perfectly fine now. And one complication which is unique to this dual mobility is intraprosthetic dislocation. You can see it if you have a good quality X-ray, a bubble sign, and then the solution for this is revision to a little bigger diameter. And overall, intraprosthetic dislocation is very, very low with improved quality of implant, just 0.76%. And it scores over all other implants by a big margin. If you compare this with a regular THR, which has threefold higher dislocation rate and sevenfold higher redislocation rate. So friends, dual mobility is a winner and in high-risk primaries and in high-risk revisions. But remember, it's not a magic bullet. It's not a substitute for your poor surgical technique. You need to restore the offset leg length and soft tissue tensions. And complications are now found to be less common in newest generation of dual mobility. So it's here to stay. Thank you so much.